Hello and welcome to the latest episode of our psoriatic arthritis podcast series alongside our rheumatoid and axSpA podcasts. We'll be bringing you monthly slide decks to help keep you up to date with the latest research and publications in the field of PSA. My name is Peter Nash, Professor at the School of Medicine, Griffith University, and Director of the Rheumatology Research on the Sunshine Coast in Australia. And joining me today is Laura Coates, Professor at the University of Oxford's Nuffield Department of Orthopaedics, Rheumatology and Muscular Sciences, and Professor Philip Meese, Director of Rheumatology Research at the Swedish Medical Center and at the University of Washington School of Medicine in Seattle. Today's focus will be on one paper, a study that assessed the long-term impact of bimekizumab, the IL-17A and F inhibitor, on patient-reported outcomes, health-related quality of life, and work productivity in patients with active PSA who were BDMARD naive or had an adequate response to TNF up to 1 year. Over to you, Philip.
Thank you, Peter. Today's paper is authored by Daphne Gladman, myself, and other authors, entitled Bimekizumab Improves Patient-Reported Outcomes and Work Productivity in Patients with Psoriatic Arthritis, 1-year results from 2 phase 3 studies. Assessing the impact of PSA on health-related quality of life from a patient perspective has been acknowledged as important by GRAPPA and OMERACT. Pain and fatigue, indeed, are now included in the PSA core domain set that should be measured in every clinical trial. EULAR recommendations also include maximizing health-related quality of life as a main treatment goal. Bimekizumab is an IL-17F as well as IL-17A inhibitor that has previously demonstrated efficacy in patients with active PSA who were bio-DMARD naive or had an inadequate response to a TNF inhibitor. This study assessed patient-reported outcomes, health-related quality of life, and work productivity in patients with active PSA who were bio-DMARD naive or had an inadequate response to TNF up to 1 year. What were the methods? B-Complete and B-Optimal were both phase 3 trials assessing the efficacy and safety of bimekizumab. In B-Optimal, patients were randomized 3:1 to receive subcutaneous bimekizumab, 160 milligrams Q4 or placebo, or subcutaneous adalimumab, 40 milligrams every 2 weeks through 52 weeks. At week 16, patients on placebo switched to bimekizumab. In B-Complete, patients were randomized 2:1 to sub-Q bimekizumab, 160 Q4 or placebo. Patients who completed week 52 of B-Optimal or week 16 of B-Complete were eligible to enter the B-Vital open label extension for 52 weeks. Change from baseline and responders in patient-reported symptoms reported the following: pain and fatigue as assessed by pain VAS and the FACIT fatigue score, physical function as assessed using the HAQ-DI, health-related quality of life assessed via a combination of an instrument known as the PSED-12, the PSA quality of life measure, SF-36, and EQ-5D, 3L-VAS. Work productivity was assessed using the Work Productivity and Activity Impairment Questionnaire. Both studies compared bimekizumab with placebo for the primary endpoint of ACR 50 at week 16. Now to you, Laura, for the results.
Thank you, Philip. So I'll move on to the first part of the results from this paper. So as Philip's outlined in terms of the study design in B-Optimal, with the biologic naive patients, 90.4% of the patients were randomized in that trial and achieved study completion. And in B complete, in those who were TNF experienced, 97% of patients were randomized and achieved study completion. And at the end of those two individual trials, 94.3% of those patients from both studies then entered that open label extension B Vital to get the longer term follow-up data. Overall baseline characteristics were similar across the studies, obviously with the key difference around the treatment experience and across the different treatment arms in the different studies. Patients who'd had a prior inadequate response to TNF had higher baseline pain scores and more work impairment compared to those who were biologic naive. So in terms of pain, this is obviously the key symptom that most patients rank as the most important to them managing their psoriatic arthritis. We can see that bimekizumab provided sustained pain reduction over 52 weeks, maintaining or even improving pain relief from week 16 to week 52 in both of those patients who were biologic DMARD naive and those who'd had a prior inadequate response to TNF inhibitors. Patients who switched from placebo to bimekizumab at week 16 then experienced a significant pain relief once they were on active therapy, and they achieved similar levels of pain reduction as those who started on bimekizumab from the beginning of the trial. If we take a meaningful level of pain reduction of at least 50% in the pain score, that was reported by 56.4% of those patients who were biologic naive and 56.9% of patients who'd had a prior inadequate response to TNF once those patients received bimekizumab in the study. For patients who initially got the placebo and then switched to bimekizumab at week 16, it was pretty similar, 56.2% of the biologic DMARD naive patients and 42.1% of those with prior inadequate response to TNF reported at least a 50% improvement in pain scores by week 52. And similar trends were observed for varying levels of pain improvement. So whether you look for reductions of at least 30% or at least 70% in the pain score, measured by the pain visual analog scale, you saw similar results from patients from the two studies who had the different treatment experience and comparing those who initially got bimekizumab with those who initially got placebo and then switched over to active therapy. So obviously the pain is, I think, usually the most obvious thing that patients complain of when they come to clinic. And it seems that this is very positive data with bimekizumab, looking at that pain response. And I'm sure matching in with the clinical assessments showing improvement in tenderness and swollen joint counts, and that translating to an improvement in pain as well.
Look, I think most interesting is the retention in these studies was something like 90%. So we're not just looking at those patients who did well staying in the trial, and it's out to a year. There was no loss of effect over time. Philip, what do you think of the FACIT score? Is there a better way of measuring fatigue? It's such a complicated symptom with so many different causes. Is there a more objective way of sorting out fatigue?
If you want to do quite expensive functional MRI scanning, yes. I'm joking. So not too much though, because we are finding that both for pain and fatigue, there's some fascinating studies with neuroimaging that are teaching us about what centers of the brain are most involved with these symptoms. And in particular, we're very interested in the inflammation-induced fatigue, where cytokine overactivity is partly involved in the central nervous system, in addition to all those other potential contributors to fatigue, like sleep disturbance or depression, or some of the medications people might be using, and so forth. So I like the FACIT. It's a multidimensional questionnaire. It's not a single VAS or NRS, which I think simplifies it too much. And at least in our country, the FDA likes it. And they're now recognizing that this is an important clinical symptom area for patients, and they're paying more attention to it and even giving sometimes an indication in the label that these medications can help fatigue. I wanted
We've
to
got a
mention one
local.
other thing, if I could, Peter, on the pain scores. In the pain research area, a 50% improvement is considered highly substantial, makes a big deal to patients. 30% is palpable, but 50% is a big deal. And the fact that more than half of the patients achieve this threshold, I think, is really something.
We've got a local company who's managed to put EEG monitoring into a baseball cap and have used taxi drivers, truck drivers, and train drivers, and the stuff goes wirelessly back to a central place. And they can pick up sleepiness, not fatigue, and the people get a phone call as they're about to nod off driving the train. But if they could somehow tweak that into fatigue rather than calling it sleep, you could put your baseball cap on and you could measure fatigue scores. That would be very nice, but it's not possible at the moment. I was going to ask you about the pain scores. Even though 50% are over 50%, what about the other percent that aren't over 50%, Laura? Is this because of all those other external elements driving pain, like damage, like central sensitization, that you can't change with an agent that's very effective?
Yeah, I mean, unfortunately, we don't see pain scores coming back to zero in most cases. And I think probably even harder here with the patients who have been TNF exposed, have had likely disease for longer before they got onto the treatment. And obviously, it's, as Philip said, this is quite a significant threshold. So a proportion of patients may not have hit 50, but they may have had an improvement of 30 or 40%, which would still be of benefit to them. And I think it does just come back to, like fatigue, pain is a very complicated symptom. It's not one thing, it's not caused by one thing. And we've got to be aware that obviously our job as rheumatologists is to control inflammation, but there's a lot more to it than that. Even when we've got people on very effective therapies like this, that are really keeping inflammation under control, there's still a lot more that we need to do to help patients with their symptoms, and pain and fatigue are always the ones that come out top in any discussions with patients.
And finally, Philip, work productivity, increasingly important metric these days?
Yes, very much so. Uh, Now that we get people back to more normal physical function, we also want to see if they are able to get back into the working environment that they may have retreated from because of the various impacts that their disease has had on them, not only on physical function, but just the energy and enthusiasm to be back in the workplace. So that's very important.
And so, shall we move on to the second part of the results, Philip?
Yes. So let's look at fatigue in more granular detail. Bimekizumab led to sustained fatigue improvement over a year with clinically meaningful reductions first observed at week 16 and maintained through week 52 in both bio-DMARD naive and TNF inadequate responder populations. Patients who switched from placebo to bimekizumab also experienced significant fatigue improvements. By week 52, bio-DMARD naive patients who switched had similar fatigue reductions to those who had received bimekizumab from the start. For patients with inadequate response to TNF inhibitors, placebo switchers showed nearly comparable fatigue improvements to those who were randomized to bimekizumab, with noticeable effects seen by week 40. Fatigue improvements were sustained or even enhanced throughout the study in bimekizumab-treated patients, with 54% of bio-DMARD naive patients maintaining improvement at week 52 and 58% of patients with inadequate response to TNF sustaining benefits by week 40. Placebo to bimekizumab switchers ultimately achieved fatigue improvements at levels similar to those who had been on bimekizumab from the beginning, reinforcing the long-term benefits of the treatment. Let's move on to physical function measures. So bimekizumab provided sustained improvements in physical functioning over a 1-year period, maintaining or even enhancing the benefits that were seen at week 16 to week 52 in both bio-DMARD naive and patients who were inadequate responders to TNF, as measured by the Health Assessment Questionnaire Disability Index, or HAQ-DI score. Patients who switched from placebo to bimekizumab at week 16 experienced similar improvements in HAQ-DI scores by week 52, achieving comparable functional benefits to those who had been on bimekizumab from the beginning. Both bimekizumab randomized patients and those who switched from placebo demonstrated similar trends in achieving meaningful functional improvements, as measured by the HAQ-DI minimal clinically important difference, or MCID, and normative value responses.
Thanks very much, Philip. Sorry, what were you going to ask? Sorry.
Any thoughts about this data?
Laura, what do you think?
I think it fits with the improvement in pain as well. Often we see sort of pain and fatigue mirroring each other, not perfectly, but often we see that where you get an improvement in one, you often do in the other. Again, you can't get rid of fatigue completely. That's multifaceted and not just due to inflammation, but you can see kind of similar response levels, that you've got quite around half or just over half getting good benefit and sustained benefit through the study, which is really, really positive.
I wonder if I'd love to always look at the patients who are greater than 70, 80, 90% improvers compared to those who are 0 to 10 to 20% improvers, and see if you can predict what are the predictors for good response, what are the predictors for bad response. Thank you very much.
I think that's been difficult in trials, hasn't it? Often you can see an early response that sort of predicts a later response, but really predicting it off the baseline data is pretty tricky.
It is.
It would be lovely to be able to do it.
But we tend not to look. We tend to bunch patients together and look at significance. And the other thing is the timeline, as you say, over time, how the symptoms change over time. Very, very interesting. With long half-life drugs, is it important to have an extremely rapid response to keep everybody happy, or should we be more interested in safety and getting the right effect over time, Philip?
Well, it's clearly a balance to achieve. Patients are wanting to get some benefit fairly quickly, and we've found with the interleukin-17 inhibitors that this can be achieved. So we see benefit as early as 4 weeks in certain measures, certainly by 8 weeks. And we don't see that much of a trade-off in terms of safety. There's a bit of an issue with Candida. It's a known issue because of the fact that IL-17 can protect against surface Candida. And when you inhibit it, you may see some oral thrush. But from a severe infection point of view, we don't really see much of a signal from we don't see issues like cardiovascular problems or a signal for malignancy. So we perceive the IL-17 class in general, and bimekizumab included, to be a relatively safe class of medication.
I think it's critical, really, as people start talking about combinations for the most difficult to treat patients. I think we don't see opportunist infection. We don't see TB. We don't see a lung full of fungus like you can get with TNFs and things. So critically important is the safety balance. We'll move on to the final part of the results, starting with the HR quality of life. Bimekizumab led to a sustained improvement in physical health as measured by SF-36 physical component summary score. The improvements seen at 16 weeks were maintained or enhanced through a year in both those who were BD-MARD naive and patients who were inadequate responders to TNF. Patients who switched from placebo to active drug also experienced similar gains by the 12-month mark. Key SF-36 subscale improvements are observed. The greatest benefit seen in physical function, physical role, pain reduction, And as Laura said, the patients are most interested pain, fatigue, and quality of life. They don't care about swollen joints, erosions on X-rays, high ESRs. Additional improvements were noted in general health, vitality, social functioning, emotional role, and mental health. And I think mental health is something we underestimate in our PSA population a lot, where depression has been a significant aspect of many of PSA patients. Indeed, it led to the cessation or subsequent difficulty getting licensed for one of the 17 receptor antagonists. So mental health by 52 weeks for the bimekizumab randomized patients and week 40 for placebo switches. PSA-specific quality of life measured showed sustained benefits, including the PSAID-12 scores, and we can talk about the PSAID in a minute, remained stable or improved up to a year, and psoriatic arthritis quality of life data demonstrated continuous improvement over time. BASDAI scores assessing disease activity and symptoms improved consistently, and we should think about BASDAI scores for peripheral arthritis type patients rather than axial patients, with total and subdomain scores showing progress up to week 52. Similar trends were seen in the proportion of patients achieving BASDAI 50, indicating a 50% improvement in symptoms. Quality of life enhancements as measured by the EQSD-3L scale was sustained through 1 year for both groups, reinforcing the long-term benefits and no tachyphylaxis over time, like you see with at least one of the TNFs. Work productivity, bimekizumab led to greater reductions in work impairment compared to placebo. Very important if you don't want to get sacked for missing work for repeated days. At week 16, patients in both the BDMARD naive and prior inadequate response to TNF population experienced larger improvements in their ability to work than those who received placebo. The gains were sustained over time, and improvements continued through week 52 for those patients treated with bimekizumab and 40 weeks for those who switched from placebo, with placebo switches ultimately achieving similar benefits. So key improvements were seen across multiple work productivity and activity impairment domains. Patients experienced reductions in absenteeism, that's the missed work days, presenteeism, which is the reduced efficacy while at work, and overall activity impairment. While all domains showed improvements, absenteeism demonstrated smaller gains compared to other measures. So they're the final of the results. So Laura, can I ask you about the PSAID-12, and where you think it should fit into both clinical practice, or should it be a research tool mainly?
No, I think it is useful in clinical practice, and it's one of the questionnaires that we often use because it covers such a wide variety of different ways that PSA can impact on you. So rather than having a questionnaire for fatigue and a separate questionnaire for pain and something else for depression, it's a very nice kind of screening tool or feasible tool in clinical practice, because you've got kind of 9 or 12 questions, depending on the version, that covers a little bit of everything. So you get an idea of how it's impacting on the individual patient. And I think that can help drive discussions in clinic. Sometimes the patients will mark something on the questionnaire that they maybe wouldn't say if they are struggling more with mood or anxiety or something and they don't want to bring that up. So I think it's a good way of kind of opening a conversation. And I think it does work well in trials because it covers a broad range of things. And it's also a bit more of a modern measure. So as much as we use HackDI, just as in this study, it's a very established questionnaire that we use. The patients don't love it. It measures quite a significant impairment of function. It's sort of a little bit old-fashioned, and really, I think, is more useful for patients in times gone by where we had less effective therapies. PSAID is a much more modern tool. It had very strong patient involvement in the development. So it really does include the things that matter to patients, which is what we're trying to measure. So I think it's very useful in both trials and clinical practice. And I think it's really positive to have data like this with the PSAID.
Is it sensitive to change and respond to treatment well?
Yeah, absolutely it does. It's like we've discussed with pain and fatigue, it's measuring multifaceted things. It's not all going to come back to zero. It's not all going to be specifically related to inflammation. But I think you can see good changes. And obviously, officially, it's validated as a whole tool. But then it has been used in varying studies and definitely in clinical practice to really pull out which individual bits of that questionnaire are impacting on a patient. So you can sort of guide the different domains of the PSAID questionnaire as well.
Thank you. So, Philip, the BASDAI in predominantly peripheral arthritis type patients, how should we interpret the BASDAI results?
When used in patients who don't specifically have spondylitis, or you don't know that, it's useful as a general measure. So a general disease activity measure. It will improve, even when the patient has no spine activity of any kind, it will improve as the patient undergoes treatment and is at high levels, even without any spine involvement. So I think that it's can be seen as a disease activity measure. When used in patients specifically with spine disease, though, we do find it an especially useful measure. It's been used forever in ankylosing spondylitis trials and now non-radiographic axial SpA trials, and in the fledgling axial PSA trials that are being done as we speak.
So the $64,000 question, we now have 317 inhibitors. We have, at our last check, 4 more under development. So where are we going to fit bimekizumab into our armamentarium? And do we need 7? Laura, what do you think?
I mean, we've had a lot of TNFs, and obviously before we had different options, we did cycle through TNFs with good response. And there are data out there looking at cycling through different IL-17s with some decent results. So I think having more than one is potentially useful. I guess the big question with this as the first IL-17A and F inhibitor is how different is that from the IL-17As on its own? And obviously we haven't got head-to-head data, which makes it difficult to know for sure. I think looking at the results from bimekizumab, it doesn't look obviously different in terms of clinical efficacy from the IL-17A inhibitors. There's this suggestion that maybe the responses were a bit better in those who are TNF experienced, and that's a really important group of patients for us. Certainly in Europe, where we have biosimilar TNF, that's where all of the drugs are really fighting for that kind of second line position because it's hard to beat the cost of biosimilar adalimumab in particular. So I think there's still more data to come. We still need more data comparing these in clinical practice and to get a better idea in real world evidence as to where it fits. But it's certainly at least as good as an IL-17A, maybe slightly better results in the TNF experienced patients. And it doesn't seem to come with a big additional safety burden. So that kind of risk benefit trade-off is still good.
Thank you, Philip. They do have some superiority in skin alone. So where do you see it fitting in, Philip?
We've been using it now pretty actively since it became available in the US. We certainly have had some successes with it in patients who have had previous use of either of the IL-17A inhibitors, have had a certain run with those medicines, but now have lost benefit. Even in those patients, we're finding good results with bimekizumab. So I think that's one area certainly that it makes sense to try. We are using it also as a first-line IL-17 class agent to use, partly because of the strength of the data, both in musculoskeletal as well as skin domains. One of the measures I like to look at a lot is one that Laura created, the minimal disease activity criteria. And we saw in the clinical trials in PSA 45% achieving MDA at week 16 in both the bio-naive and bio-experienced populations. That's really solid data. So So we like it a lot as a medicine to use that has all those features that Laura mentioned, including a good safety profile, fairly quick onset of action, and now, as we saw today, some of the key symptom areas that patients experience, really good benefit there.
It's interesting, we've had similar experience, Philip, where people who do not give an immunogenicity story of loss of effect of their 17, it's not, used to last a month, now only lasts 3 weeks, 2 weeks, 1 week, but loss of effect, and you switch 17s and they have a dramatic response. So if you blocked all of 17, that's very interesting why the 17 should suddenly work, a little bit like all the TNFs and their differences and uniqueness. Laura, conclusion, please.
Yeah, so I think this study shows really nicely that bimekizumab treatment resulted in sustained improvements in patient-reported symptoms, and that covered pain, fatigue, health-related quality of life, and work productivity, with up to a year follow-up in the biologic DMARD naive patients and in patients who'd had an inadequate response to TNF before and had entered those PSA trials with bimekizumab. And the improvements that are reported in this paper add to the already published 1-year efficacy and safety data from the trials before, looking at the clinical outcomes, demonstrating really, as we've just discussed, the efficacy of bimekizumab across both clinical and patient-reported symptomology in patients with psoriatic arthritis.
So thank you, Laura. Thank you, Philip. And thanks for joining us for this PSA podcast brought to you by the Immune-Mediated Inflammatory Disease Forum. We really hope you've enjoyed it and found it useful. If you did, don't forget to subscribe to our channels on YouTube, Spotify, SoundCloud, or wherever you get your podcasts so that you don't miss any future episodes. If you want to read more about what we've discussed today, visit imidforum.com, where you'll find detailed summary slides for today's publication. See you for our next PSA podcast. Thank you very much.